Honorable President of the Sri Lanka Medical Association, members of the Council, past presidents of the Sri Lanka Medical Association, my dear teachers, respected colleagues and friends, and distinguished guests. It is with deep humility and immense pride that I stand before you today to deliver Sir Nicholas Attygalle Oration, an honour of singular distinction in the academic and professional life of a Sri Lankan medical practitioner. When entrusted with an oration of this stature, one cannot begin without pausing to remember the man whose name it bears. This oration carries the name of Sir Nicholas Attygalle, a figure whose service and leadership left a lasting impact on medicine, education, and public life in Sri Lanka. Trained both as a surgeon and a gynecologist, he became one of the most respected clinicians of his time, known for precision, discipline, and dedication to patient care. His influence, however, extended far beyond the operation theatre. Sir Nicholas was appointed the first Ceylonese Vice-Chancellor of the University of Ceylon in 1954, at a time when the country was still finding its footing in higher education. He held the post for more than a decade, providing strong leadership that safeguarded academic standards and institutional independence. His reputation for fairness and firmness earned him respect among colleagues and students alike. Many of the systems and practices introduced under his tenure laid the foundation for modern university education in Sri Lanka. His contributions to medical education was equally significant. As a committed teacher, he guided generations of students in surgery and obstetrics, combining high expectations with personal mentorship. Many of the pupils that he tutored and guided became leaders in medicine both nationally and internationally, carrying forward the values of discipline, clarity, and professional integrity that he instilled. Beyond medicine and academia, Sir Nicholas also served the country in public life. He became the first medical professional to be appointed to the Senate of Ceylon, where he was recognized for his measured judgment and ability to engage constructively with national policies of that time. His service demonstrated that doctors could play a meaningful role, not only in treating patients, but also in shaping the intellectual and moral direction of the society. Remembering Sir Nicholas Attygalle today reminds us that the leadership in medicine is not defined only by the positions held or the titles bestowed. It lies in the standards we set, the systems we strengthen, and the generations we inspire. His life stands as a clear example of knowledge applied with purpose and of service grounded in principle. It is in this spirit that I now turn to the subject of today's oration. The focus of my presentation today is unseen, unspoken, and unsafe, the epidemic of toxins threatening our children, a topic that addresses a critical and timely issue within the child health care landscape. I hope it echoes in some small way the ideals that Sir Nicholas Attygalle so steadfastly lived by. Before I start, I declare that I have no conflicts of interest with regards to this presentation. Home, a place where childhood should unfold with safety and joy, too often conceals silent threats that endanger young lives. Across the world, injuries remain a leading yet profoundly preventable cause of morbidity and mortality in children. In Sri Lanka, they account for the fourth leading cause of death among children, a tragic reminder of overlooked risk in everyday environments. To eliminate these hidden dangers, we conducted an observational cross-sectional study at the Lady Children's Hospital, Colombo. Our study explored domestic risk factors across 4 domains: burns, electrocution, poisoning, and accidental trauma. We interviewed caregivers of 400 children under 12 years and uncovered an alarming level of preventable hazards within the domestic environments. This work was published in a supplementary edition of the Archives of Diseases of Childhood. In this oration, I will bring special attention to three issues that are often overlooked: poisonings, substance abuse, and snake bites in the pediatric age group. Globally, pediatric poisoning remains a significant yet under-recognized public health concern. Moreover, there are marked disparities between regions. Sri Lanka records an incidence rate notably higher than many high-income countries. This means that there is an urgent need for targeted prevention strategies in our context. While the overall number of deaths from pediatric poisoning has declined in many parts of the world, it remains disproportionately high in low and middle income countries. Sri Lanka's mortality rate reflects persistent challenges in pre-hospital care, timely access to treatment, and public awareness. Acute poisoning in children is largely underexplored in the public health discourse in Sri Lanka. In one of our earlier studies, we sought to address this gap by investigating the demographic patterns, clinical management, and the outcome of acute poisoning in children living in rural Sri Lanka. Our multi-center study spanned over 7 years and was conducted across 36 regional hospitals within the North Central province. We gathered data on a range of variables, including clinical profiles of the affected children, types of poisoning agents, delays in medical interventions, and complications arising from acute poisoning. From a total of 1,621 children presented with acute poisoning, the majority were preschool aged. Household chemicals, particularly kerosene oil, were implicated in nearly 20% of cases. This was our rural Sri Lanka. We observed a high transfer rate, and the mortality rate was 0.4%. As you all know, this is quite low compared to adult poisonings. We saw that most incidents primarily occurred within the confines of child's home. Over 15% presented with delay. Complications, although rare, were serious, with chemical pneumonitis being the most common. 7 deaths were reported, and we published this work in BMC Pediatrics. The impact of poisoning can often be made worse by the practice of potentially harmful first aids by the caregivers. Our study recruiting 384 children under 12 found that nearly 30% of caregivers administered some form of harmful first aid measure. Practices such as inducing vomiting with large amounts of water were significantly associated with low maternal education, remote healthcare access, and certain cultural beliefs. Interestingly, children from rural areas and those with asymptomatic poisoning were more likely to receive inappropriate pre-hospital care. Our study highlighted the need for targeted interventions to educate caregivers on safe first aids and improve healthcare access. In light of these findings, it's imperative that we focus on raising community awareness, improving first aid practices, and encouraging timely medical interventions. This work was published in BMC Research Notes. Why do children ingest a poison accidentally? To find this out, we conducted a case control study to explore over 23 risk factors that were reported from the worst of the world. We recruited 600 children under 5 with acute poisoning and age and sex matched controls. Our analysis revealed 8 risk factors that were significantly associated with accidental poisoning in children. The findings highlighted that inadequate supervision by parents, unsafe storage of poisons, and an unsafe home garden as the primary risk factors for accidental poisoning in children. It is important to assess how community education can help parents stay vigilant, store potential toxins safely, and to make the home garden safer for our children. Focusing on these areas can potentially and greatly reduce the childhood poisoning in rural communities. This work was recognized, earning the Outstanding Oral Presentation Award at the Asia Pacific Academic Consortium for Public Health South Korea in 2017. And subsequently, this work was published as a full paper in International Journal of Pediatrics. Medication safety in children. Drug poisoning in children remain a critical public health issue, particularly in low and middle income countries. In Sri Lanka, accidental drug poisoning often stems from limited parental awareness and delay in seeking care. This delay can exacerbate poisoning outcomes, placing further strain on an already burdened healthcare system. To address this, we assess knowledge, attitude, and practices of primary caregivers regarding prevention of accidental drug poisoning. A total of 385 primary caregivers from Colombo North Teaching Hospital participated, completing a 42-item questionnaire. The results revealed that most caregivers were aware of the risks associated with drug overdoses. However, significant gaps existed in understanding proper medication dosing and the dangers of drug interactions. Despite this awareness, many caregivers reported unsafe practices. Notably, they included administering medications without prior consultation with a health provider, and nearly 30% still attempted to induce vomiting in children at home following the poisoning event. Better knowledge correlated with better practices. Our study underscored the need for targeted educational programs that focus on both knowledge gaps and unsafe practices. We published this work in BMC Research Notes. Self-medication practice among parents in Sri Lanka is also a growing concern. Many treat their children's common illnesses without seeking advice from health professionals. This practice is widespread, with parents often relying on their own experiences or perceived harmlessness of the symptoms when deciding to administer medications. Our results based on 270 parents revealed that nearly 80% of parents practice self-medication. Fever was the most common symptom that the children were self-medicated with. Factors driving self-medication included the perception of symptoms being harmless and the parents' own experience of treating similar symptoms in past. While self-medication may seem like a convenient and cost-effective solution to some, it can lead to serious health consequences, especially if the wrong medication is used or the dosage is incorrectly administered. Addressing this issue is essential for safeguarding child health and ensuring safer medical practices in Sri Lanka. This work was presented at the annual Congress of the Sri Lanka College of Pediatricians in 2025. How could this lack of knowledge, unsafe attitude, and self-medication practices impact on health and safety of children? Let's now turn to children who actually had medication poisoning. In our series of 410 pediatric pharmaceutical poisonings, errors, but not curiosity, accounted for 14% of medicine poisonings. Wrong dose poured by a parent or wrong drug dispensed by a health provider. 3 commonly self-medicated drugs were paracetamol, salbutamol, and chlorpheniramine, and they caused the most events. Remarkably, no fatalities occurred, yet every hospital admission strained families and the ward beds. As revealed from our qualitative work, accidental drug poisonings in children often arise from a complex interplay of factors. At its core, caregiver errors such as mistaken administration remain frequent. System-related issues including pharmacy dispensing errors and unclear instructions further compound the risk. Unsafe storage practices and gaps in parent knowledge, particularly regarding dosage and toxicity, emerge as critical preventable drivers of these tragic events. This work was published in the Asia Pacific Journal of Medical Toxicology. Is it only the caregivers who should be held accountable for the medication errors in children? We know that safe prescribing is the cornerstone of child health and safety. Yet in many settings, evidence of fragmented documentation and antibiotic excess have been largely anecdotal. We undertook a multi-center study to quantify this problem and illuminate regional variation of safe prescribing practices in Sri Lanka. In a cross-sectional survey of 1,400 outpatient prescriptions made for children under 5 across 7 districts, we benchmarked every script against WHO quality indicators. Notably, Typed prescriptions outperformed handwriting on legibility, completeness of frequency and duration fields, and more importantly, the accuracy of drug-related information. This finding highlights that typed prescribing could be a valuable addition to the safer prescribing practice, reducing the risk of misinterpretation, dosing errors, and incomplete instructions that often compromise patient safety. Our findings mirror low middle-income country trends, incomplete weight documentation, brand name bias, and liberal antibiotic use. These silent deficits will perpetuate dosing errors and antimicrobial resistance. Mandating e-prescribing templates that lock without weight, dose units, and duration, and coupling this with targeted stewardship can transform every prescription from a potential hazard to a precise instrument of care. Although it may seem impossible or unachievable, we will see light at the end of the cave through collective efforts. We presented this work at the annual Congress of Sri Lanka College of Pediatricians in 2025. Pesticide exposures and child safety. Pesticides remain a notable cause of acute childhood poisoning in Sri Lanka. Our study highlighted that organophosphates and carbamates were among the leading agents, with younger children particularly vulnerable to accidental ingestions within the home environment and while they help their parents in fields. In our series of 155 pesticide poisonings, we observed that children presented with a wide spectrum of clinical manifestations. They range from mild gastrointestinal symptoms to severe life-threatening toxicity. Mortality rate was almost 6-fold high compared to mortality from all other poisons. These findings emphasize the urgent need for regulatory enforcement. Establishing poison information services and strengthening primary healthcare response are essential steps to reduce this burden. Compared to adults, most accidental ingestions in children are fortunately harmless. Yet, the fear they provoke often lead to unnecessary admissions to our wards. We must ask, can we not do better? With careful triaging at the pediatric emergency departments, we can identify those who are at risk, while safely discharging those who are not. Such an approach would preserve precious ward beds for the sickest of our children. I would like to draw your attention now to a quieter, darker facet of childhood poisoning, deliberate self-poisoning among Sri Lankan teenagers. Born of psychological pain, fractured hopes, and too easy access to toxic substances, these acts are cries for help that too often end in irreversible harm. And uncovering its roots, it's vital to protect young lives and guide prevention. We conducted a large retrospective study across 7 referral hospitals in 5 provinces. We were able to capture all deliberate self-poisoning cases among teenagers under 17 for a period of 3 years, ending at 2024. In total, we recognized 2,782 teenagers with deliberate poisoning. Nearly 3/4 of that were female teenagers, with a mean age of 15 years. Pharmaceutical agents dominated, responsible for over 60% of cases. Agrochemicals and toxic plants were also common in rural areas. Most teenagers were successfully discharged, but 9 tragic deaths were reported. The deaths were due to pesticide and oleander ingestion. Our findings confirm that deliberate self-poisoning is an urgent public health challenge for Sri Lankan adolescents. The striking female predominance and the predominance of pharmaceutical overdoses highlight the need for better medicine regulation and parental education. In rural settings, pesticides and toxic plants continue to take young lives, calling for stricter control and awareness. The path forward must combine restriction to access of lethal substances with strengthened adolescent mental health support. We presented this work at the Middle East and North Africa Medical Toxicology Association Annual Congress, Oman, in 2025. What drives Sri Lankan adolescents to deliberately poison themselves? To explore this in detail, we conducted a prospective multi-center case control study. The study was done across 6 tertiary care hospitals over a 2-year period. 326 adolescents with deliberate self-poisoning were enrolled. Each case was matched one-to-one with a control adolescent of the same age and sex, admitted to the same hospital for non-psychiatric acute medical conditions. Our study illuminated a complex web of psychosocial factors driving deliberate self-poisoning in Sri Lankan teenagers. The findings painted a sobering picture of a population in psychological distress. We found that adolescents with a personal history of psychiatric illness, particularly depression, were nearly 3 times more likely to engage in self-poisoning. Alarmingly, many had harmed themselves or attempted to poison themselves before. Yet, many had not received adequate psychiatric follow-up. One of the most distressing and urgent revelations from this study was the profound vulnerability of sexual and gender minority youth. In our analysis, non-heterosexual orientation emerged as one of the most potent independent risk factors, with adolescents identifying as LGBTQ+, being nearly 27 times more likely to engage in deliberate self-poisoning than their heterosexual peers. The staggering association underscores the hidden yet devastating impact of sexual identity-related distress in a context where adolescents face pervasive stigma, invisibility, and criminalization. School-related stress was another major factor. Academic pressure, bullying, and grade retention created a toxic environment of failure and fear. Adolescents who had dropped out of school were 4 times more likely to self-poison, reinforcing that disengagement from education is not merely an educational issue, but rather it's a red flag for deeper psychosocial instability. Ladies and gentlemen, despite adolescent deliberate self-poisoning is rapidly rising in Sri Lanka, evidence on survivor trajectories is limited. It represents a different facet of this pressing adversity faced by our teenagers. We conducted a multi-center follow-up of 400 teenagers aged 11 to 17 years, identified from 5 referral hospitals, and interviewed a median of 3 years after their initial poisoning event. Structured telephone surveys captured repeat self-harm, perceived health, and social functional status. Our results revealed that the recurrence was common. 15.8% reported that at least one further act of self-harm, and 7.5% repeated self-poisoning. 4 factors independently forecasted repeat poisoning: lifetime suicidal ideation, a personal psychiatric diagnosis, current antidepressant therapy, and a self-rated sense of overall poor health. We published this work in BMC Research Notes. I will now navigate in a different direction of toxins in children. Substance abuse in the pediatric age group. Across the world, the challenges faced by teenagers are rapidly changing, and one of the most alarming is the growing threat of substance abuse. In Sri Lanka too, we are beginning to see worrying signs that the drugs are creeping into the lives of our adolescents, bringing them with the risk to health, education, and society at large. To understand this problem accurately, data more than just assumptions are essential. We examined substance use amongst 12 to 17-year-olds in the western province of Sri Lanka. We used urine toxicology as our standard. This was a cross-sectional study of all positive immunoassay urine screens collected at 4 major referral centers between February 2020 and January 2024. 69 adolescents met our inclusion criteria. The mean age was just 16 years, and more than 90% of them were male. The data showed clear patterns. Age correlated positively with confirmed drug use, and male sex was independently associated with higher detection rates. What substances were we seeing in teenagers? Cannabis, or tetrahydroxycannabinol, was by far the most common, detected in 87% of cases. Methamphetamine, we commonly know this as ice, followed at almost 1/3, while opioid variants, commonly this is known as heroin, and benzodiazepines were detected in just over 10% each. Cocaine and profoxyphene were rare but were present. Polysubstance use was also seen. And around 16% of teenagers in this population used more than one drug. Most often, it was cannabis combined with methamphetamine. What does this mean for us? It means our response must be both early and targeted. As we all know, these revelations are just the tip of the iceberg. We need gender-responsive school programs. We need enhanced urban surveillance. And we need rapid referral pathways for at-risk teenagers before an occasional use turns into multi-substance dependence. Despite adolescent substance misuse in Sri Lanka is increasingly evident, the empirical detail on its driving factors has been limited. To address this gap, we undertook a case control study within 2 state rehabilitation centers in Sri Lanka. 92 in-house children, nearly all male and averaging 14.5 years, were compared with an equal number of age and sex-matched school peers over a period of 1 year. Through structured interviews, we charted drug use histories, family structure and peer context, and then modeled this data within multivariable logistic regression to isolate independent risk factors. The profile that emerged was distinctive. Cannabis was the entry drug for 80% of teenagers abusing substances. This observation was similar to our previous study. Amphetamine followed closely at 79%, and more than half had misused prescription medications. First exposure clustered around the age of 13, and the initiation was rarely solitary. Over 80% described this as trying it for fun, while 76% reported overt peer pressure. In almost every instance, a friend supplied the first dose. The family setting added further vulnerability. 1/3 carried a recognized family history of substance misuse. 1/5 lived with a single parent. And more than a quarter had witnessed domestic violence fueled by a parent's drinking or drug use. 22% had a sibling who is also abusing drugs. When these factors were examined together, 3 factors stood out statistically robust predictors as leading to ongoing substance abuse. Having substance-using peers increased risks more than 6-fold. Perceiving stronger peer pressure quadrupled it. And a positive family history tripled the odds, independent of the age and sex. Being diagnosed with a psychiatric disorder, parental separation, belief that the substance increased popularity, and the association with gangs were the strongest risk factors. On the other hand, positive discipline at school and strong peer relationships were protective factors. Taken together, these findings position peer influence as the dominant accelerator of adolescent drug use in Sri Lanka. Familial exposures and family-related vulnerabilities provide a potent secondary current. Effective prevention must therefore move on 2 fronts. Peer-directed programs within schools that reshape norms and resist group pressure, and family-centered counseling that interrupts intergenerational transmission of substance use. Ladies and gentlemen, it's now time not to burden these vulnerable young people with stigma. Instead, we must bring them into the circle of care, support their rehabilitation, and help them rediscover their place in our society. We know that children born to substance-abusing mothers face increased risk of physical health adversities and emotional trauma. This is not just a theoretical issue, but a harsh reality faced by a noteworthy number of children in Sri Lanka, especially from vulnerable populations. To understand the gravity of this situation, we conducted a 2-year retrospective cohort study at the National Prison in Colombo. Our study involved 182 mothers who had been incarcerated due to substance abuse and their children under the age of 5. These children, whose future being reshaped by circumstances of their mothers, were compared with a control group of children matched for age and sex. We collected data through structured questionnaires, which included a range of health and developmental indicators. The results were nothing short of alarming. Sympathomimetic, or ICE, and not cannabis were the most commonly abused substance by these mothers. Common occupations of this group of marginalized mothers included spa work, night clubbing, and drug dealing. Children born to substance abuse mothers had significantly higher rates of low birth weight and NICU admissions compared to the control group. The rates of low birth weight was more than 3 times the rate observed in the control group. Similarly, NICU admission was almost 3 times more frequent among children of substance abusing mothers. Postnatally, the challenges continued. Children of substance abusing mothers were more than 11 times as likely to have delayed vaccinations compared to controls. Growth faltering was about 2 times more common in these children, with 1 in 5 affected. Developmental delay, particularly in speech and language, was 4-fold high among children of substance abusing mothers. These findings underscore deep vulnerabilities these children face from birth as they navigate not only the physical impacts of prenatal substance exposure, but also the emotional and social strain of being raised in such challenging environments. This work was recognized earning the Taylor and Francis Award for the Best Oral Presentation at the Asia Pacific Medical Toxicology Congress, Malaysia in 2024. In this group of studies, perhaps the most striking were the qualitative findings from our focus groups. The discussions revealed that stigma, psychosocial stress, and limited healthcare access were significant barriers preventing these mothers from seeking help they desperately needed. The mothers themselves expressed feeling abandoned by the healthcare system, trapped in a cycle of substance use and incarceration, with little support to break free for the sake of their children. Moreover, the lack of integrated healthcare services that address both maternal and pediatric needs means that these children are not getting the timely interventions they need to thrive. It is a call to action for us as a society to rethink how we approach maternal and child health care, especially for the most vulnerable among us. This work was published in BMJ Pediatrics Open. Let me now turn to the final and perhaps the most formidable category of toxins that afflict our children: snake envenomations. Snake envenoming, a WHO-listed neglected tropical disease, poses a disproportionate threat to our children, especially in agrarian regions. Sri Lanka reports one of the world's highest bite incidences, yet pediatric epidemiology remained inadequately addressed. We undertook a multi-center analysis to characterize the demographics, epidemiological patterns, and seasonal distribution of pediatric snake bites across 7 provinces. This retrospective cohort of all children under 17 presenting with snake bites to 9 governmental hospitals over a period of 4 years were assembled from hospital-based data. Trends were assessed using chi-square tests. We recruited 757 children with snake bites, and nearly 60% of them were males. Snake identification was achieved in nearly 60%, that is 442 cases. Medically important taxa comprised, in descending order of frequency, hump-nosed viper, Brussels viper, common krait, and cobra. Incidence peaked around 10 to 12 years. Monthly distribution demonstrated a bimodal elevation during yellow cultivation season and the northeastern monsoons. Dry zone centers recorded higher proportions of Brussels viper and krait bites, while the wet zone centers reported a higher number of hump-nosed viper bites in children. The male preponderance and the 10 to 12 year peak coincided with unsupervised agricultural activity. We found that snake species and seasonal patterns parallel ecological niches and agronomic calendars. Sri Lankan pediatric snake bites exhibited a clear demographic and spatiotemporal signatures. Our findings supported targeted antivenom allocation to pediatric wards, monsoon season community education, and child-focused protective measures to mitigate this preventable pediatric threat. This work was recognized, earning the first runner-up for the Best Research Poster at the Sri Lanka College of Pediatricians Annual Congress 2025. Ladies and gentlemen, today we have traced some silent threats that haunt the lives of our children, from unseen dangers within our homes to toxic exposures born of negligence, ignorance, poverty, and isolation. Behind every statistic, there lies a child whose poisoning, injury, or loss was and still is largely preventable. Our findings are a clarion call to action. Prevention is not the work of chance, but of intention, woven through timely advice, safer homes, better awareness, responsive healthcare, and a society that listens before it's too late. And so, I will now take you through how far we have come in our journey of establishing children's poison information services and what more remains to be done. With the partnership of Ministry of Health Sri Lanka and the University of Edinburgh-based NIHR Right 4 initiative, we have been able to establish the dedicated helpline for pediatric poison information. This milestone, embodied in KidsTalks LK, marks the beginning of a transformative journey, the creation of a children's poison information service. Though still in its infancy, the vision is bold: to grow into a national service that prevents tragedies, strengthens treatment, builds awareness, and safeguards every child's health following exposure to toxins. This would have been impossible without the generous support of our colleagues. I want to sincerely commend the medical toxicology specialists who provide their services entirely on an honorary basis, and the NIHR Poison Centre specialist based at the Edinburgh, the UK, and South Africa, whose expertise and guidance have been invaluable. I am humbled and privileged to collaborate with poison scent experts across the globe, strengthening our capacity through shared knowledge and experience. Partnerships with recognized regional networks such as Asia Pacific Medical Toxicology Association and Middle Eastern and North Africa Medical Toxicology Association have been invaluable. These collaborations not only enrich our work locally, but also ensure that we contribute meaningfully to the global toxicology community. The Global Academy of Clinical Toxicology has played a pivotal role by training some of our poison information specialists through programs conducted in South Africa, Malaysia, and Oman. They have provided the expertise and practical knowledge needed to design and run effective children's poison information center. This international collaboration has directly strengthened our capacity to provide timely, evidence-based guidance, laying the foundation for a national service that protects children from poisoning. Through the Specialty Board in Medical Toxicology at the PGIM and its Master's Program in Medical Toxicology, we have developed vital expertise that would also strengthen the poison information services. As a toxicology forum of the Sri Lanka College of Pediatricians, we collaborated with other national bodies to design and conduct workshops, training doctors and other healthcare professionals regarding pediatric snakebite management. We conducted capacity building workshops for rural pediatric doctors, equipping them with the knowledge and skills to manage pediatric snake bites effectively. These sessions focused on early recognition, timely intervention, and referral protocols to improve outcomes. Workshops for public health midwives in rural Eastern Province trained them in prevention, first aid, and community education on pediatric snake bites. They now serve as frontline educators, bringing the most underprivileged families with timely guidance and support. Training sessions for postgraduate emergency medicine trainees at the PGIM emphasize advanced pediatric snakebite management. This initiative strengthens emergency response capacity building and prepares the next generation of specialists to handle pediatric snakebite cases confidently. We were able to translate research into practice and to accumulate global evidence to resolve pressing challenges in management of pediatric poisoning, especially within our local context. We developed an illustrated textbook of over 52 real-life pediatric toxicology cases designed for pediatric doctors and postgraduate trainees. This resource provides practical insights and guides clinical decision-making in managing childhood poisoning. We also had the privilege of guiding students through a thoughtfully designed question and answer book tailored for MBBS and MR Chem examinations, with a special emphasis on pediatric toxic ingestions and envenomations. Books on pediatric snakebite prevention and first aid, published in all 3 state languages, were created to empower parents and vulnerable communities. These resources enhance awareness, encourage timely action, and strengthen community-led response to pediatric snakebite risks. Reaching the unreachable through education beyond barriers. We deliver key messages to the public on pediatric snakebite prevention and first aid through distance learning. Our YouTube channel, embraced by over 9,000 subscribers, extends this knowledge to families and communities across Sri Lanka, empowering timely action and safe practices. Acknowledgements. Let me take a moment to remember and acknowledge those who have been crucial in this journey thus far, and whose support, guidance, and encouragement have made this work possible. With heartfelt gratitude, I acknowledge my alma mater, Lanka College, Colombo, where my journey in learning began and lasted for 13 long years. The Faculty of Medicine, University of Colombo, where I nurtured my passion and thrived in medicine. And the Faculty of Medicine, University of Attygalle, where I have now the privilege to serve. Each institution has shaped my path, inspired my commitment, and empowered me to contribute to what I do today. My journey has also been shaped by advanced training in pediatrics at the PGIM Colombo, with a number of its affiliated hospitals, especially at the Lady Ridley Hospital, Colombo, and John Radcliffe Children's Hospital in Oxford. These invaluable opportunities have not only honed my clinical skills, but also inspired a lifelong commitment to advancing the health and well-being of children. I'm ever so grateful to each and every teacher who inspired me and guided shaping the path that has led to serve today as a professor in pediatrics. With deepest gratitude, I acknowledge my written supervisors whose guidance, wisdom, and unwavering support have shaped every step of my research journey. Their patience, insight, and encouragement have been a beacon, inspiring me to pursue excellence and meaningful contributions in pediatric intoxications-related research. I also extend heartfelt thanks to my mentors, both local and overseas, whose expertise and perspective enriched my understanding and broadened the horizons. Their mentorship has been invaluable in guiding me to integrate global best practices with local needs, nurturing both the growth and impact of my work. In grateful collaboration, I extend my heartfelt thanks and deepest appreciation to all research collaborators and research assistants whose shared vision, dedication, and teamwork have made this journey possible. Their commitment and expertise have been the foundation of every step forward. Let me acknowledge the entire family of the Pediatrics Department at the University of Attygalle and the North Colombo Teaching Hospital. Your unwavering support, guidance, and camaraderie have been a pillar of strength, turning challenges into shared achievements and successes into collective celebrations. And finally, with all my heart, I remember and thank my beloved family, my wife Dilini and my daughter Hirundi, and my parents, including my late father. Your love, patience, and unwavering support have been my foundation, inspiring every step of this journey. This work is as much as yours as it is mine. Thank you all, ladies and gentlemen, for your patient listening.